oncology inpatient nurse for 9 years. Her areas of interest include multiple myeloma and CLL, and her personal interests include running, hiking, biking, and playing with her beautiful daughter. So if you all would welcome Victoria to the stage.
Good morning, everybody. I just want to thank everybody for being here and coming from wherever you came from. I know that there's even some people here from Atlanta, so thank you so much. Just quick question for everybody. Does anybody here, who deals with CLL and myeloma? Raise your hands. Oh, I have a good group. Dr. Shana Khan, you are not allowed to raise your hand on that one. So I'm going to start with CLL. So my whole purpose in this discussion is really, there has been a lot of advances since about the 2015 mark as far as drugs. So I want to give you a little bit of a basic overview on both disease processes, as well as talk about the drugs that are now available and how they are being used, to make sure that everybody's familiar with them in some form and what to look for with them. I do have a very limited amount of time to talk about these two disease processes, so I'm going to kind of go through it pretty quickly. If anybody wants me to stop, please raise your hands and I'll talk about something, okay? So CLL, basic definition. CLL is a neoplastic disease characterized by proliferation and accumulation of morphologically mature but immunologically dysfunctional lymphocytes. Teenagers, that's what I think of them as. Most common leukemia in Western adults, 25 to 30% of all leukemias, 4.7 out of 100,000 per year, predominantly a disease, thank you, of the elderly with a median age of diagnosis of 65 years old. When they get older, we do see an increase in the rate, and male to female ratio, we do see more men than women. 5-year survival rate based on 2007 to 2013, 83.2%. That's a good survival rate. This is a disease that is chronic. We are not talking about an acute disease. And it's also something that commonly, if cytogenetics are good, we can look at somebody and say, this is a disease that you will likely die with and not because of. So clinical features and presentation. A lot of times people end up in hematology because of primary care noticed an elevated lymphocyte count on routine blood work. It was repeated, noted again, they come and see us, and then we start from that point. Or they do have some palpable lymph nodes, organomegaly, or we are seeing anemia, neutropenia, and thrombocytopenia due to more bone marrow involvement. Also, people will have recurrent infections due to hypogammaglobulinemia. So what are B symptoms when we talk about this? We look at low-grade fevers. They're having them at a frequent rate. Palpable lymph nodes, night sweats. This is not I am hormonal and I'm a little wet around my